Hello and welcome to this edition of the Center for Podiatric Education. In this discussion, I'd like to just review my experience and some of the literature relative to a not uncommon problem that all of us have encountered in daily practice, that being the problem of plantar fibromatosis. Plantar fibromatosis is a problem that we frequently see in everyday podiatry practice. These fibromas are generally benign. They are firm to palpation. As you know, they may be single or multiple in presentation. They may be symptomatic or non-symptomatic. Usually they are minimally symptomatic, at least initially. Some progress to become increasingly tender, and some do become painful. When I see patients with what I believe to be plantar fibromatosis, I ask about their hands, and I do take a look at the palms and fingers. There is a association and increased frequency of other fibromatosis-related problems in patients with plantar fibromatosis, so-called letter hose disease. They have an increased frequency of palmar fibromatosis and may have been diagnosed with either Dupuytren's contracture or trigger finger. If it's a male, I ask about Peyronie's disease and whether there are any penile lesions present. Some of these patients also have increased thickening over the proximal interphalangeal joints or the metacarpal phalangeal joints of their hands. And then there are a number of less commonly, pretty rare associated disorders that have been related to plantar fibromatosis. We do see this with increased frequency in patients that have diabetes, particularly patients with diabetic neuropathy. It is seen with increased frequency in patients that have seizure disorders. And it is felt that the reason for this is that dilantin, or phenytoin, inhibits 50 to 60% of collagenase activity, and it is felt that there's a loss of normal collagenase activity, as a result of which fibromatosis is seen much more commonly. It is also seen with increased frequency in patients who have a history of alcohol abuse and hepatic disease. Again, the associations include trigger finger and diagnosis of Dupuytren's contracture, and as you see to the right, and increased incidence of knuckle pads with thickening, collagenous thickening of the metacarpal phalangeal joints, as well as the interphalangeal joints of the hands, as is illustrated here. These lesions are typically benign. There is a superficial type that tends to remain within the medial and central bands of the plantar fascia. There is a more aggressive form that can be locally invasive. These are generally referred to on histologic examination as a desmoplastic fibroma. Fibromatosis is seen with increased frequency in men. It is most often bilateral, but may certainly be unilateral. Particularly the more aggressive forms may be invasive into the fat, into the dermis, and into the intrinsic muscles. And for this reason, in proceeding with any surgical intervention, I think it's important to perform a careful examination in surgical planning, which includes either ultrasound or MRI evaluation. If there is involvement in the dermis, then it is important to consider possibly excision of the skin overlying the fibromatosis mass itself, a so-called dermatofasciectomy, because there will be fibroma plaquing on the undersurface of the skin, and we go ahead and perform surgery to bulk the major part of the tumor, but then when we lay the skin back down, we're laying fibromatosis mass back into the wound and passing sutures back and forth through that into the skin. I think another thing that is very important to realize is that not infrequently these masses will encroach on cutaneous nerves, and in particular may encroach on the branches of the medial plantar nerve. This is not at all uncommon, and it is important to look for evidence of nerve compression syndromes and document the presence of a nerve compression syndrome prior to any surgical intervention, because neurologic complications following excision of a plantar fibroma is one of the most common complications that is reported when surgery is performed. And you can have entrapment of the nerve due to invasion of the fibroma into the nerve, due to compression of nerves by the mass of the fibroma. Injury may occur during surgery, and injury to the nerve may occur due to postoperative scarring that can occur. And for that reason, it is important to recognize the presence of any preoperative nerve compression syndromes, alert the patient to this problem, and document this accordingly. The examination typically is that of a patient who presents with, again, palpable nodule or nodules. At times there may be a prominent one or two nodules, and other less developed occult nodules may be present. They can also be found in other areas, and while we typically tend to see them in the mid-arch or a distal mid-arch, they can occur in the forefoot, and they have been described by others, and I've personally had experience with finding plantar fibromas under metatarsal heads in the plantar fascia distally, and can mimic other etiologies of metatarsalgia, such as plantar plate rupture or interdigital neuroma. And you can also find them at the insertion of the plantar fascia. A nice histologic study done by Pressman and Associates, published some years ago, showed that a substantial percentage of patients diagnosed with seemingly classic plantar fasciitis who were recalcitrant to care and underwent surgery demonstrated surgical specimens consistent with fibromatosis. Obviously, there may be some degree of tenderness. More importantly, there may be patients experiencing pain. And again, it's important to seek out, document, and alert the patient to any nerve compression syndromes. There are less commonly encountered forms. You can find fibromatosis in the juvenile patient. There is, in fact, a form of juvenile plantar fibromatosis. Typically, they're seen between the ages of 40 and 60, but really can occur at almost any age. They may be calcified on occasion. There are classification systems for plantar fibromatosis, and I do alert the patient to the natural history of these lesions. Initially, there is a proliferative phase in which fibroblasts and spindle cells dominate. Histologically, there's marked fibroblastic cellular proliferation and a perivascular round cell infiltrate, particularly at the margins of the lesion. And this is the time that the lesions are actively growing. Now, these lesions do contain a cell called the myofibroblast, kind of a transitional cell between a fibroblast and a smooth muscle cell, and these result in eventual contracture of the fibromas, and typically this is when they become painful. So the lesions become slightly smaller in many patients, but more indurated and become increasingly painful. There is then a residual phase, again, with maturation of the collagen within the mass and contraction of the lesion itself. There are also applications of classic tumor staging that can be applied to any bone or soft tissue tumor, and this is certainly applicable to the plantar fibroma. If one wishes to look at the Enneking staging system, generally these lesions, if they're not aggressive and not a desmoplastic type of lesion, are restricted to the plantar fascia and stay within the plantar fascia itself. But again, there are more aggressive presentations of these lesions that will go beyond the plantar fascia, invading the fat and dermis, proceeding in a more superficial direction, and invading the deeper fascia and muscles, going deeper into the bone, into the soft tissues rather. The differential diagnosis of a plantar fibroma is really that of any soft tissue tumor. And over the years, I have had occasion to excise what I have believed to have been plantar fibromas or worked up patients for what I thought were plantar fibromas who turned out to have various diagnoses. This would include patients who have had leiomyoma tumors, neurofibromas. Certainly in the rheumatoid patient, rheumatoid nodules need to be considered. Subcutaneous scars and fibrosis following trauma are always a consideration. I've also had one patient that appeared to have a rather typical plantar fibroma who had an amelanotic melanoma, and certain sarcomas have been reported as part of the differential and mimicking plantar fibromatosis, including liposarcomas, fibrosarcomas, and even rhabdomyosarcomas. The clear cell sarcoma is problematic only in that its radiographic imaging characteristics on MRI can closely resemble a plantar fibroma. Now, typically after examining a patient, I will tell them I believe they have a plantar fibroma, and I will typically tell the patient that while it is highly likely this is a benign lesion, that we either want to obtain an MRI or a diagnostic ultrasound or a biopsy of the lesion percutaneously to assure that it is in fact consistent with a plantar fibroma. Although we see these patients commonly and we reassure them that their history and findings are consistent with a plantar fibroma, the fact is that statistical protection is not absolute protection. One could obtain standard radiographs initially looking for any evidence of calcification or bone destruction. The typical examination I will follow with is an MRI. MRI will typically demonstrate a well-defined mass projecting along the inferior margin of the plantar fascia or within the plantar fascia. On T1 imaging, we'll typically see low signal intensity compared to the adjacent muscle with gadolinium contrast on T1. There's going to be some degree of variable contrast enhancement, and on T2, there's an intermediate signal compared to the adjacent muscle. Diagnostic ultrasound can also be used to image plantar fibromas, and typically this will show a fusiform hypoechoic to mixed nodule formation with moderate acoustic enhancement. So over the years, one sees various presentations of plantar fibromas both on MRI or on diagnostic ultrasound. And generally, if I have a patient with a typical history, typical clinical findings, and typical MRI or ultrasound imaging suggestive of a plantar fibroma, I do not proceed with biopsy, although I do discuss the potential to do a biopsy if that's what the patient desires, although I try to reassure the patient that everything points to a benign fibroma. In considering biopsy, this can be done percutaneously with or without ultrasound guidance. One can generally palpate the lesion readily, and I'll discuss the advantages and disadvantages with the patient. My major concern with biopsy is that of any biopsy of a soft tissue lesion, that is tracking of the lesion should it prove to be something other than a plantar fibroma and in fact be malignant, so that in planning my approach for biopsy, whether it's fine needle or other percutaneous technique, I always plan the biopsy such that the track for the biopsy can be easily excised at the time of definitive resection of the lesion. Typically, I do not perform a biopsy personally if the patient has the typical clinical and typical imaging characteristics. Pathologically, the lesions generally show a proliferation of fibroblasts, spindle cells moderate to increased cellularity. There may be the presence of the transitional cells, the myofibroblasts. Whorls of collagen are generally seen on the pathology with perivascular lymphocytic infiltrates, and occasionally there's calcification within the lesion. The lesions not infrequently contain this transition cell, the myofibroblast, which is derived from fibroblasts in the presence of mechanical stress in the presence of stimulating factors such as transforming growth factor beta. We have conversion of the fibroblasts to the proto-myofibroblasts, again in response to stress, then conversion into the myofibroblast, which has contractile properties and may be responsible for some of the later induration of this mass. Over time, these lesions either go apoptosis or de-differentiate back into fibroblasts. One of the reasons that we've seen some attention to calcium channel blockers is that, as you know, fibroblasts will produce procollagen, which is assembled extracellularly and cross-linked into collagen, and this requires calcium. We know that the production of calcium is dependent on many cofactors such as vitamin C, which is responsible for proline and lysine being incorporated into making collagen. Conversely, drugs that inhibit the absorption of calcium, such as calcium channel blockers, are helpful in reducing the production of collagen by blocking intracellular production of procollagen and interfering with cross-linking. And this is one of the reasons that calcium channel blockers such as verapamil are frequently utilized for the treatment of plantar fibromatosis. The treatment of plantar fibromatosis is based upon the signs and symptoms that the patient is experiencing. The majority of patients, in my opinion, are very successfully treated by non-operative care. So the first stage is a proper history, physical examination, looking for associated syndromes, again, such as Dupuytren's contracture, trigger finger, perhaps undiagnosed diabetes. We then want to do the best we can to make an appropriate diagnosis, so not infrequently we will reassure the patient by obtaining either a diagnostic ultrasound, MRI, or a percutaneous biopsy. Once we've established the diagnosis, I discuss the natural history of this disorder with the patient and the fact that they may have occasional discomfort in certain shoes, particularly with harder insoles or more rigid type arch supports, that there may be some irritating factors, but that over time most patients do well and do not require surgical intervention in the majority of cases, period. I discuss with the patient the risks and benefits of non-operative care and the risks of operative care, and this is very important. There are some patients that come in and are rather cavalier in asking for removal of the lesion, and I try to explain to the patients, maybe I shouldn't say try, I do explain to the patients that while this may be a minor annoyance, that surgery for plantar fibromatosis can be associated with a high rate of recurrence, scarring, nerve injury, and wound healing problems, and that they could end up with an area that is much more symptomatic than they were prior to surgery. And I tell them that, in my opinion, they would be best treated by non-operative means. I do reappoint the patients to be seen probably every 6 months or so for a reevaluation. I try to get some measurements obtained through the skin. I advise the patient to avoid hard insoles and any type of rigid orthotics. I do ask the patients to stretch the plantar fascia, and this can be done by active stretching typical to the programs that we would utilize for the treatment of plantar fasciitis. you can incorporate some type of night splint if you think it is appropriate to do so. I tell the patients that they might benefit from, and I will frequently utilize a soft, accommodative type of insole. Colchicine has been utilized for the treatment of palmar as well as plantar fibromatosis, and it's been reported to have some success in patients, and therefore I at times will recommend oral colchicine. And then topical therapy. I have had over the years tremendous success utilizing topical therapies. Now, verapamil at a concentration of about 15% has been established as being very helpful in the treatment of fibromatosis when applied transcutaneously or percutaneously. And that is because verapamil is a calcium channel blocker. It inhibits the synthesis of collagen. It stimulates to some extent the production of collagenase, and the lesions become softer, less indurated, and less painful. So 15% verapamil has certainly been established for quite some time as helpful not only for plantar fibromatosis, but also Peyronie's disease and Dupuytren's contracture. I have had wonderful success by combining verapamil 15% together with 5% lidocaine and 5% diclofenac, or adding baclofen between 3 and 5%. I think the baclofen is helpful when there is the infiltration of the myofibroblast. There is literature that has suggested that in some patients, anti-inflammatory medications are helpful for the treatment of plantar fibromatosis, and we want to remember that the conversion of fibroblasts to the proto-myoblast and myoblast is stimulated by cytokine activity, which can be reduced with the use of an anti-inflammatory. And then, of course, lidocaine, which provides some degree of analgesia. And I've had just a wonderful success for many years now with the combination of verapamil, lidocaine, and diclofenac, or verapamil, lidocaine, and baclofen, or a combination of all four, utilizing these as a compounded medication. Now, generally, these are not covered by insurances, and there is some expense to the patient. And I do take the time to explain to the patient that with stretching and with the use of these compounded medications, their lesions will probably reduce in size, hopefully be less indurated, hopefully become less painful, and interdict the need for surgery. And I think it's important for patients to understand that this is a surgery that can be associated with a significant risk of sequelae and complications. And I find that patient cooperation and adherence to the protocol of utilizing these topical compounded medications together with stretching is very, very helpful if one takes the time to explain to the patient the need to be cooperative in their care. Injection therapies have also been recommended. You have individual published reports of various injection therapies with varying degrees of success. Some have advocated the monthly intralesional injection of triamcinolone together with lidocaine, 1 injection per month for 5 consecutive months with some degree of success. Some have advocated the application of therapies typically utilized for Dupuytren's contracture of the hand, and probably the most common right now is that of injectable collagenase. Now, the only problem here again is that for use in the foot, this is not an approved therapy, and therefore the patient must undertake to meet the expense of the therapy. Injections of 5-fluorouracil have been suggested as a possible therapy for plantar fibromatosis, and there's been some reports of success, and injections of hyaluronidase have been reported again as being helpful in reducing the size and symptomatology associated with plantar fibromas. There are other therapies that have been reported with success. This includes percutaneous cryoablative surgery. Extracorporeal shock wave therapy has been reported as being successful in some patients with plantar fibromatosis. Physical therapy, primarily with therapeutic ultrasound, has been reported as being associated with decreased frequency of pain and intensity of pain with plantar fibromatosis, and radiotherapy has been reported with success for the treatment of plantar fibromatosis. Now, we get the occasional patient that has more aggressive forms of the disease, patients who have increasing pain and disability, who do not respond to non-operative care and require surgical intervention. Because of the risks of potential sequelae and complications, I think it's important to reserve surgery to patients with rapidly growing and painful lesions, or patients that have significant pain from nerve compression syndromes. And in such circumstances, I think it's important to document the extent of the patient's pain or disability or the presence of some neurovascular symptomatology. One of the things I do routinely is feel for the mobility of the skin overlying the mass. And if there has been infiltration of the fibromatosis mass into the skin, then I alert the patient to the fact that the lesion is on the undersurface of their dermis, and that skin's going to have to be excised at the time of the surgery. Otherwise, I'm going to replace the fibromatosis mass back into the wound, and I think this likely accounts for some of the reoccurrence rate that we see. So that being the case, we want to plan both on clinical examination as well as with preoperative ultrasound, or personally I prefer preoperative MRI, to see if there are any occult lesions that are present, the extent of the fibromatosis, the extent of invasion both superficially and deep, and whether or not I'm going to therefore be performing a local excision, or whether we're going to be performing a wide excision with subtotal fasciectomy. So if the overlying skin is not mobile, then I plan on doing a dermatofasciotomy, really a dermatofasciectomy, and this can include the need for skin grafting in an occasional patient. And I think it's very important that patients have appropriate symptoms and that they understand that there is a high risk of reoccurrence, a high risk of hematoma, seroma, scarring, and nerve injury. So the degree of surgery performed is dependent upon our preoperative clinical as well as our preoperative imaging studies. And these can range from smaller incisions with localized excision of a small portion of the plantar fascia to more extensive dissections to really almost total fasciotomy, or rather fasciectomy. And again, as is illustrated to your right, you can see that in some cases the extent of dissection is such that we could appreciate how scarring or surgical injury, or preoperatively there may be compression injury to the branches of the intrinsic nerves to the foot, in particular the medial proper branch of the, or rather the medial plantar nerve. I do look for invasion in the undersurface of the dermis, as is illustrated here. So not uncommonly, one makes an incision and you realize that you're making an incision right through the fibromatosis itself, which is adhered to the dermis. And if we replace that skin in the wound, then we're transplanting or transferring the fibroma mass back into that skin, and now we're passing sutures back and forth, tracking more and more of this tumor into the skin, so that if we find that there is preoperatively or intraoperatively evidence of fibromatosis on the dermal side, then I think it's very, very important to excise this or engage in some therapy. Some have suggested post-operative use of calcium channel blockers. Some have suggested post-operative radiation therapy, but it's important to account for the lesions on the undersurface of the dermis itself. Rather high rates of complications and sequelae have been reported with plantar fibromatosis surgery. Wapner reported that postoperative neuroma formation, or we should say nerve symptomatology, wound healing problems were found in as high as 52% of patients. And yet, with all the problems reported, the overall patient satisfaction rate is generally around 86%, which means that a not inconsequential 14% of patients are not satisfied with the surgery. So that's certainly greater than 1 in 10 and something that we need to consider. When one does isolated nodule excisions and does not do a more expansive fasciectomy, it's recommended that a minimum of 1.5 centimeter clear margin be included with the excision of the fibroma. Recurrence rates with isolated nodule for excision have been reported as high as 75 and in some instances 100%. However, in doing a subtotal fasciectomy or including a dermatofasciectomy, reported rates of recurrence really are much lower, just under 10% of patients, but still not inconsequential. And this is why patients need to be warned about the possibility of recurrence. So in summary, plantar fibromatosis is something that we see commonly in practice. We want to do our best to assure a proper diagnosis. We want to educate the patient regarding the disorder itself, the benign course it typically follows, and the risks and benefits of non-operative care. We do know that statistically most patients do well with non-operative management of this problem. We know that patients undergoing surgery should understand the risks associated with that surgery, particularly the risks of nerve injury and recurrent lesions. But generally, patient satisfaction rate is high when excision of fibromas is performed.